Okay, so we went through the traditional approach, the mean approach, and now let's talk about what we call maybe the preferred approach or the motivating approach, maybe the coaching, the good coach approach. This approach doesn't assume that people haven't suffered enough. I mean, come on, we all have suffered a lot in our lives, right? It helps clinicians to be mindful of our own suffering and the suffering of others. It's not about making them suffer. It's about understanding that people feel ambivalent. On the one hand, they like that thing, that habit that they have, they're stuck in it. And on the other hand, they want to change. So they're ambivalent. People continue drug use and bad health habits because of their ambivalence. And sometimes the most ambivalent people manifest as the most vocally nasty people. So just because someone's very vocal about their stance doesn't mean that deep down they don't also have ambivalence. So we have to understand that motivation is the key to change. Motivational has a lot of different components to it because it consists of internal urges and desires felt by the person, external pressures and goals, thoughts, perception of risks and benefits, and etc. Motivation is constantly going up and down, and it's very much influenced by social interactions, especially in teenagers, right? So motivation can be modified and improved, and a good clinician will be skillful about drawing out people's natural motivation. It's influenced by the clinician's style, which means establishing a helping alliance that leads to better outcomes. So the clinician's task is to elicit and enhance motivation within the client, not to confront or punish them. So what is ambivalence? Ambivalence means feeling two ways about something. And all change contains an element of ambivalence. And for motivational interviewing, what we say is that we're resolving ambivalence in the direction of change. So the carrot or motivational approach is fostered by an accepting, non-judgmental, empowering way of interacting with people that makes them feel safe and respected. So why don't people change? So you would think, so this is also proof of the fact that the stick approach is wrong, because you would think that when a man has had a heart attack, it would be enough to persuade him to quit smoking, change his diet, exercise more, and take his medication. Or that hangovers, damaged relationships, and auto crash, memory blackouts, or even pregnancy would be enough to stop a woman from drinking. You would think that experiencing the dehumanizing environment of prison, that people would not reoffend. These are all examples of some pretty punishing stuff. And yet, harmful behaviors persist despite the overwhelming evidence of their destructiveness. So all of the aforementioned people will tell you how their life sucks because of what they've done. So why don't people change? It's not that they don't want to see, they're not in denial that they don't care, that they have no motivation. So think back to last week. They're not changing because they're just in the early stages of change. So that's where that trans-theoretical model really helps you to conceptualize where a person is. How do people change? Well, there's some ways that people change even without our help. In many problem areas, change occurs without treatment. The stages and processes by which people change seem to be the same with or without treatment. Treatment should be thought of, or our counseling should be thought of as facilitating the natural process. Also, faith and hope. A person's perception of how likely it is that they can succeed in making a particular change is a good predictor of the likelihood that actual change will occur. The effect of believing often brings about 30% of the outcomes of treatment. And so when we believe in patients, we can, hopefully the belief is going to be contagious, and they may believe in themselves. And also, and this is especially good for you to know, because maybe your employees or you will only see a person once or twice. Often, skillful use of motivational interviewing techniques is enough to trigger change. 1 or 2 sessions can yield much greater change than no counseling, and a little counseling can lead to significant change. The dose effect of how many times you interact with someone may have some positives in some areas, but research shows that it's not always the case. Motivation can be defined as the probability that a person will enter into, continue, and adhere to a specific change strategy. So therefore, motivation is the key to change. It's multidimensional, and it's dynamic and fluctuating. And very much influenced by the clinician's style. It can be motivated, and our task here is to elicit and enhance motivation. If we're sensing in our client a lack of motivation, that's a challenge to our therapeutic skills, and not a fault for which the client is blamed and labeled as unmotivated. So some of the general strategies we're going to be using are special ways of giving advice. So if I just jump in and start telling you what to do, remember that's the directing style. So there's ways of giving health information that are consistent with motivational interviewing practice. Removing barriers for change, providing choices for people. Decreasing the desirability of continuing in the old ways. Practicing empathy, providing feedback, clarifying goals, and active helping. Each of these is a skill to be learned and practiced. So some of the counseling can actually be more technical than you might think. Remember ambivalence. Ambivalence is normal. Clients usually enter treatment with fluctuating and conflicting motivations. They want to change and they don't want to change. Working with ambivalence is working with the heart of the problem. So examples of some motivational statements might be cognitive recognition of the problem. So these are things that you might hear a client say. I guess this is more serious than I thought. How about an emotional expression? I'm really worried about what is happening to me. Direct or implicit intention to change behavior. I've got to do something about this. And optimism about their ability to change. I know that if I want to, I can really do it. So when we're talking to people, we are listening for these kinds of motivational statements, which we call change talk. So our 4 guiding MI principles are, first of all, to resist the righting reflex. If a patient is ambivalent about change and the clinician champions the side of change, what will happen? So if I tell you, you should quit smoking because you're going to die of cancer, what are you going to do? You're going to come back at me with, but I've tried to quit and it's so hard, and by doing that, you're just talking yourself out of changing. So we don't want to champion the side of change. We want the patient or client to champion the side of their own change. We want to understand our particular client's motivations. What causes them to want to do the things that we want them to do? So we have to pretty much directly ask them what their reasons are and why they might choose change rather than staying the same. We want to listen. When it comes to behavior change, the answers most likely will lie within the patient. So we have to listen to their reasons and talk about their lives and respond in a way that helps them pursue their own goals. And we want to empower them by making them active participants of a conversation about change, getting them thinking aloud about the what, why, and how they could change, and then they're more likely to do something about it. Okay, so as we wind up for today, let's see how you do on the motivation post-test. Until a person is motivated for change, there's not much we can do. True or false? I hope you said false, because remember, it's my job to set up the discussion so that the client's motivation for change increases as we talk. It usually takes a significant crisis or a reaching rock bottom to motivate a person to change. Again, I hope you said false. It takes a good clinician to help motivate someone. Motivation is influenced by human connections. Hope you said true. Resistance to change arises from deep-seated defense mechanisms, like denial and repression. Okay, hope you said false. It can arise due to negative interactions with healthcare providers, especially in a client who doesn't want to be told what to do. People choose whether or not they will change. The answer is true. So we want to help them choose positively for themselves. Readiness for change often involves a balancing of pros and cons. That is also true, right? If I can really see that the pros outweigh the cons, then I'm more likely to take some steps. Creating motivation for change usually requires confrontation. Okay, the answer here is false. Remember, when we are confrontational with clients, all we do is turn them off to the healthcare system and leave them further traumatized. And most of our people that we're working with are already coming from trauma. They don't need more trauma from us. Denial is not a patient problem, it is a skill problem. That answer is yes. We use a guiding style, we can help a person resolve some of their ambivalence. Okay, so I hope this class went well for you and got you thinking about communication between clinicians and health workers and the public, and how we want to use a guiding style, and how we want to draw out people's motivation to be healthy and to make the changes that we're trying to facilitate.